incredible organizing here in Brooklyn. We had an excellent all-star team on the ground for more than a year, doing work outreach to community organizations to inform folks about the New York Health, get them involved in activism around this bill. And I would just like, before we really get going, if you are on the planning team for this event, could you just stand up so we can recognize you? I know Marion, Anna, Ellen, of course, and one of the anchoring organizations here in Brooklyn has been the Pakistani American Youth Society, and we have Kasha sitting right up there. And of course, you'll see on the slides a rotating list of incredible logos from the many, many endorsing organizations. So thank you so much for helping to make the turnout tonight so successful. So we are coming off of a historic primary and election season. We have in New York seen some pretty historic power changes in the New York State Senate. And if anybody has been following progressive politics, which I'm sure folks in the room have been, you are thrilled at the prospects for moving a progressive agenda forward here in New York State, and that includes the New York Health Act. I mean, in any given year, there's about a 10% chance that an incumbent loses their seat, and we saw between the primary and the general election, at least 13 incumbents ousted because they weren't doing the will of the people. Yeah. And those who replaced them in the state Senate ran on a bold agenda that included the New York Health Act, guaranteed health care for all New Yorkers. Right here in Brooklyn, races for state Senate that had amazing outcomes included Zelnor Miri, Andrew Brunardis, and Julia Salazar. So they are new friends we have in Albany, and we are excited to work with them to hold their colleagues accountable in the state Senate. And I really believe there is such a sense of urgency around healthcare. I think that's reflected by the turnout tonight, but also a lot of times we really need to remember how rooted we are in this as an issue that affects us personally, right? And I know that in my own life, so many of my decisions have been made around accessing healthcare. I mean, as a young adult and growing up, I grew up in a family where my father ran a small business, and there were just plenty of times we didn't have insurance. And I know that that's a common phenomenon in this country, right? But then, as I got older, you know, there were these vivid memories of, you know, the time my boyfriend got a kidney stone, and we were worried about an emergency room bill. So he treated it at home with marshmallow tea. There's a debate about which is more painful, a kidney stone or labor, childbirth. So it's a very painful thing. We got married shortly after so that he could be on my health insurance plan. I mean, I'm really lucky. I still like the guy, right? But, wow, health insurance can dictate a lot about our lives, and unfortunately, there is a flip side to that, which is people stay in marriages that they're not happy with, or even unsafe in, jobs that they're not happy with because of health insurance. And I know today my daughter is 4 years old, and we've been to the urgent care now a few times for popcorn kernels in her nose. And it's $250 a pop, and it is a horrible feeling to think, do I have the money in my bank account to get the health care my child needs? So
of seniors, of people with disabilities, of family caregivers, and of home care workers. And I'll tell you more about what we're fighting to win in a moment. I want to start off by just, like Katie was modeling, really sharing with you all what brings me into this work and what my connection is. We're called the New York majority because of what we know to be true, which is that the vast majority of Americans, of New Yorkers, of, I'm sure, people in this room have their own personal connection to care. So I'll start off with mine. Very briefly, it is, as guess, a much longer story than what I'm about to tell you all, but when I was about 13 years old, I had the really incredible blessing of being able to live with my grandfather. He was aging in his own house, so he came and moved in with my mom and I. And something that was really incredible about this moment in time is that it coincided with my mom actually going back to school and really having the first opportunity in her life to invest in herself and to grow her education. It was, unfortunately, very difficult for my mom to be pursuing this, taking care of me, taking care of my brother, and taking care of my grandfather. And so a lot of what was happening in our home was actually a pretty intricate network among everyone in our family to really be taking care of my grandfather and making sure that our family was, able to eat regularly, all those things. So one of the things about this moment in time that I just want to be clear about is that it was both one of the most joyful times of my life. I got to spend such beautiful time with my grandfather, learn about him, learn about his life. I learned a lot about baseball. And it was also a really difficult struggle of a time. And our hope with our work that we're going to be talking about tonight and that you all will hopefully be doing with us is really in the vision of being able to support people in a way that my family really desperately needed and didn't often have, to support people to have more of the joy of being able to take care of each other, being able to connect with each other and make sure that we have what we need and less of that struggle and that grind, right? So the New York Caring Majority, what are we specifically doing? Our coalition, as I said, of seniors, people with disabilities, home care workers, and family caregivers, is really, we are dreaming of a world where care and care work are deeply valued, both in how we understand their importance, but also in how much we're paying home care workers, what home care jobs are like. And so specifically what we're fighting for is to pass single payer with the full inclusion of long-term care, right? Guaranteeing universal access to both healthcare and to home care. And at the same time, investing in home care jobs, making home care jobs a sector where people can both take care of other people's families and also be able to take care of their own, right? And so, very specifically, we're going to talk a little bit more about how folks can get involved, but there is a lot of opportunity to take action with us, meeting with each other, bringing in new people, meeting with legislators, taking action together to really change that narrative, how people are understanding this work, etc. I would love to meet with anyone who's more interested, and I'm really excited for our panel tonight to dig in to a lot more of these issues. So thank you all so much.
And before we hear from a few more folks, we'd like the Borough President to share a few words with us. Thank you for being here.
Thank you so much for this important conversation. I really want to thank Fein and Zahara. I saw them on the street as they were pushing this through the last electoral cycle, talking to some of the candidates and those who are running for office and how do we engage in this conversation around healthcare. Many of you know how important this issue is for me. As here in Borough Hall, we talk about healthcare all the time. As a person who reversed my diabetes by looking at alternative methods of dealing with the healthcare crisis. This is an important conversation, and I don't want to be lost in this conversation as we deal with healthcare for all, is how we have to really unlearn what we learned and look at preventive measures as well. And that's the holistic approach that we're looking to do here in Borough Hall. We have to stop feeding the healthcare crisis. Our Babies cannot continue to eat food every day in school that is causing long-term health care crisis. We have to stop feeding inmates in Rikers Island food that is promoting and causing diseases. Our hospitals need to have healthy meals as a default, as we get ready to announce with Health and Hospital Corporation. As we push to ensure that healthcare is for all, we must realize that the road we're on is not sustainable. We're going to bankrupt this city and this country if we continue to have a reactionary medicine model that is really not sustainable as the country. You can't continue to see dialysis center open as fast as McDonald's open. You cannot continue to see the high number of diabetes. Flatbush has its own definition of diabetes called Flatbush diabetes. So the goal is not just keep feeding the crisis. The goal is to create an environment that can start here in the borough of Brooklyn of how do we raise healthy children and families. In those cases where we need health care, it should be health care for all. We won the Senate. We have a Democratic Senate now. This bill has passed four times in the Assembly. The conversation is now going to shift to the Senate and the governor's office, but it must be a dual approach. We must have quality health care. No one should be afraid when they have to deal with a medical crisis, but it's extremely imperative that we change our mindset that real health care is preventive health care, not going to the emergency room, but doing things in our daily lives that prevent us from having to have hospital visits. My 80-year-old mother reversed her diabetes because she decided to change her lifestyle. She's no longer imprisoned with insulin, medicine. She's doing the right things holistically, and that is the mission that I have as the borough president. I thank all of you for pushing this initiative forward. It's crucial. When we need a doctor, we should be able to have a doctor, not based on our W-2 form and income, but based on the right to health care and the right mindset. Thank you very much.
So I want to welcome up two of our next speakers, and I thank you all for welcoming them with me, Allison, Julien, and Devki. What's your name, Devki? They are going to briefly share a little bit more of their own personal stories, which will model for us our next section. So we'll take, I think we have about 4 minutes right now.
Hey, good evening, everyone. Good evening, everyone.
Hi.
Awesome, that's better. So my name is Allison Julien. I'm here representing the National Domestic Workers Alliance. And I'm here to share a little bit with you about why healthcare is important to the constituents that we serve. I, too, used to be a nanny for over 25 years here in the Borough of Brooklyn, Manhattan. And understanding as a nanny providing care for the most valuable assets of a family's life, which is their children, I many times had to go to work sick. I many times had to negotiate my health with my employers. And for me, it was really frustrating seeing that as a care provider, I didn't even have the space to take time off of work to take care of my own needs. We went ahead in 2010 and we passed the Bill of Rights for domestic workers, making it the first bill to protect domestic workers here in the state of New York. And in that bill, there's coverage for domestic workers to take time off to take care of their needs. And we're also covered under the Paid Sick Leave Act, which is really important for this community. Why this is important is because many workers like myself here across the city show up to work every day sick. And if I'm sick, the babies that I care for are going to get sick. The families that I'm providing care for is going to get sick. And we have to recognize that health care is an important issue for all of us. I still don't understand why health care in this country is not universal. And I think that that's why we're all here tonight, to discuss this issue as to why this is important. Currently, I can tell you a story of a worker that I'm currently working with who recently found out that she has breast cancer. The industry that we organize are mainly undocumented women, when they are providing care for their own families, can't oftentimes provide care for themselves. And this is an issue that we as a community need to pay attention to. There are workers who oftentimes show up to work and they never leave. They leave in a body bag because they didn't call into work sick that morning. They end up dying on the jobs. These are stories that we don't talk about across our communities. We don't talk about these stories in this industry. And it breaks my heart that I have to stay here to talk about how terrible it is, the problems of healthcare within our community. And I know it's not only in the domestic worker industry, but it's in so many industries across this country. And I feel like together, as we continue to lobby and legislate for healthcare for all of us, it's an important victory that we will win, because all of our lives depend on better healthcare. Thank you so much.
Hey, good evening, everybody. So my name is Devki Joshi. I'm a proud graduate of CUNY Brooklyn College, and I'm currently a fourth-year medical student at SUNY Downstate in Prospect Leopard Gardens, and I'm planning to go into obstetrics and gynecology this July. So I've had the immense honor to train and serve patients here in Brooklyn at Kings County, Downstate University Hospital, Maimonides, and Methodist. So no matter which that healthcare setting may have been, for-profit or public, private or safety net, I see patients needlessly suffer because they can't afford their prescription medications, procedures, and treatments. What's the point of my training if the system does not allow me to apply my learning to practice? It's absolutely infuriating. I'll share two stories with you guys. On my surgery rotation, I met a woman who came to the clinic because of a growing mass on her neck. It was likely thyroid cancer, and actually it was a cancer that could be treated. However, first we would have to confirm what type of cancer it was through a biopsy. So the clerk walked in and shuffled through some paperwork and let us know that the patient couldn't afford the $15 copay for the procedure that day. The patient walked out of that clinic without the biopsy, treatment, management, and we didn't see her again. So the first day we come into medical school, we put on a white coat and we take the pledge to do no harm, yet we're constantly complicit as providers in sustaining a system of harm. And then just 2 weeks ago, I had a patient who was a 65-year-old retired man whose kidneys were no longer holding up. Without intervention, he would have likely weeks to months to live. We took the time to discuss dialysis with him. That was his best option, and without skipping a beat, his first question was, how much will this cost me? He had no desire to leave his family in debt. With his life on the line, he could only think about what he could do to not be a burden to his loved ones. So to be a compassionate physician, I need a system that allows me to provide compassionate medicine. These barriers to care make the crushing difference between life and death, which undoubtedly have a ripple effect on family units, to communities, and to our nation as a whole. There is no doubt in my mind that the New York Health Act is a necessary, logical, and compassionate step forward for New York State. I have full confidence that together we can achieve it.
Thank you very much for your stories. We're going to take a few minutes now and really, as was just modeled, as we heard about workers, about doctors, about family caregivers, seniors, people with disabilities, we're going to find and share for a few minutes together our own connections to these issues, to healthcare and to home care. So we're going to ask you in just a moment to turn to the person next to you, and we'll take about a minute and a half per person. And I want you to share what is bringing you here tonight. What is your connection to care? So I will start us off, and I'll let people know when to switch and when to come back together, and then we'll hear a little bit from folks. Sound good? Let's start. What is your connection to care?
it impacts my access to be able to be productive and then also, frequent my doctor's visits and stay on top of them. I've had to we might have opportunity to teach that
midwives are like, hierarchies, like and they're maybe like because literally every person you can talk to, it applies to like everybody. I really wanted to.
If you haven't switched yet, make sure the next person is speaking. Okay, let's go back together. I'll ask you to start saying your last sentence and then look back up immediately, please. All right. So let's begin. I want to hear a few different reflections, something that you heard that struck you or that was particularly moving or meaningful. So I would love for a few hands to go up and we'll take a few to start.
Well, one of the things we shared is how the course of 4 days and how quickly you can run up a significant,
I'll repeat it.
a significant bill depending upon what is happening in your family situation.
Yes, thank you very much. We just heard how significant co-pays can be and how they can run the bill up very quickly. Thank you. Yes.
So I came to this country as a child immigrant, and I was sharing that story. So I was sharing this story, Suzanne, and I was telling her that I came to this country as a child immigrant. And growing up here, our case in the Justice Department was thrown in the flunk, so we were without papers for 12 years. And during that time, it was very hard on my family. I was young, so I didn't have to go to hospitals or see doctor. But my mom was diabetic and I was a heart patient. And I saw the suffering that she couldn't afford a proper health care. And she would lie to us that she went to a doctor, that she would skip medications and skip doctor trips. And neighbors didn't even know she was suffering. Nobody knew until like I really grew up and I saw like what it did to my mom. Her health worsened. I wish she had some kind of coverage back then. So this connection between me and your health legislation is very personal.
Thank you very much. I really appreciate you sharing. Can I get one or two more? Yes.
Hello, everybody. So I have couple stories I was sharing with a nice bathtub overhead. My mother passed away in February from breast cancer. She didn't have sufficient health insurance, so she really just couldn't get the proper care that she needed. So it just came to a point when she just decided, you know what? I've accepted my fate, and that's how it's going to be. Just let me be comfortable, let me enjoy these last moments with my people, and I'll be fine. So that was really very difficult for all of us to really, and there's nothing that we can do. And then also now, I am currently a nanny. Good. And because my mom passed before the process of the immigration process was completed, I'm just kind of like stuck now, wondering like what to do. So I don't have access to this either. So I'm in a position where I have to really try so hard not to get sick. You understand what I mean? Like, I'm doing all the reading of the different horrible stuff or the preventative just so I don't get sick, because I can't afford to be sick. And then also as a nanny, where you're caring for children, you oftentimes get employers who will tell you, well, if you call in sick today, don't bother coming back, your job is not going to be here for you anymore. And then sometimes I wonder, if you really truly care for your children, would you want me to come to work sick, to make them sick? Like, does that make any sense to you? And there's currently a story, because I do some volunteer work with NWA, of a nanny who was working in a wheelchair. She broke her leg, and the family said, well, no big deal, come to work with a wheelchair. So she's in the park with a very active child. How is she supposed to provide proper care, and why would you want your child in the care of someone who is not mobile? So these are some things that we see and have experienced when it comes to healthcare.
Actually, I think let's end there. That was a very powerful series of stories. And I mean, I know for me, I felt it very deeply when you were sharing about your mother, so thank you very much. And just to say, I'm sure it's apparent to everyone, and probably it came through in everyone's stories in some way, that this issue is affecting people in every place of our society. This is an issue that cuts across race, region, class, so in so many different ways. It's an issue that impacts, like we said, the vast majority of us. And that is a very difficult thing to really comprehend and to really take in, but it is also our power. We can build an unstoppable movement of people based on the fact that in this room, I am sure we would be able to fill the rest of our time here with your stories. So I really look forward to us continuing to hear from one another throughout the evening, and also really getting to learn more about these issues and being able to take all of our learning here tonight and be able to turn that into action together. So thank you all so much. I'm going to turn us over to our next section, and thank you for sharing your stories.
So we're diving into our panel tonight. I'm going to introduce you to Winn, Periyasamy, who is the policy analyst with FPWA, a broad network of nonprofits, 170, I believe, throughout the state. And she is going to introduce our esteemed panelists tonight. Let's hear it for Winn. And the panelists can come on up first.
Thank you so much, guys, for taking the time out to share your stories and to really think about health equity tonight. It's really powerful. So as our panelists are coming up, your seats are over on the side here, guys. I'm going to start by introducing you to Ollie Fein. Dr. Oliver Fein is the chair of Physicians for National Health Programs, the New York Metro chapter. He is also a practicing internist and professor of clinical medicine and public health at Weill Cornell Medical College, as well as the associate dean, and has many more qualifications. It's a pleasure, and he is going to kick us off by giving us an overview of this thing called the New York Health Act, what it means, and why we should care so much about it.
Okay. Oh, I did. I'm so sorry. No, it's fine. Great. So it's really, really a great honor to be here, and in particular, one of the things that attracted me to be here tonight is that I live in Brooklyn. So that seemed to me to be a special opportunity.
Brooklyn.
So, have we gotten it up? Whoops. No, we're in a different world. You're in a different world. Okay. My first slide really has to do with a disclaimer. That is to say, I do not believe I have any relevant financial relationships with commercial interests that shape this talk. But you have heard that I am the local chapter chair for Physicians for a National Health Program, but I have taken absolutely no compensation from that organization. If anything, I have given money to it. So, starting off, let me say first that yes, we all are aware of the Affordable Care Act, also named Obamacare, and 92% of Americans agree that we all have a right to affordable care, and that's something that's really very exciting to, in fact, be aware of. But Obamacare has not solved the central problems in our healthcare system. There are still close to 28 million people who have no health insurance. There are millions more, frankly, who are underinsured. They have to pay cash out of pocket before their insurance kicks in, or they have to pay a co-payment or things of that sort. And costs continue to rise, and physicians actually object to the micromanaging of medical practices in an attempt to control costs. We have to do all those clicks on computers so that we can maximize the revenue that our institution collects or that we personally collect. So that what you see here on a slide like this is that, a family premium, on average, in an employer-sponsored health insurance is now costing $19,600. Did you realize that? And the average worker is contributing $5,547 to pay for that premium, whereas the employer, again, because unions have negotiated it, usually is paying somewhere around $14,000. So this is an enormous cost, right? And private health insurance coverage continues to decline. And what you see here back in 2008, we had, over 55% of people that were employed had health insurance, and now we're down to lower or below 50% of people who are employed have health insurance. And frankly, there's also a shrinkage of retirement coverage. Many employers gave you a retirement package to help compensate for some of the inadequacies of our Medicare program. But you can see that's gradually declining as well. And Medicaid enrollment is in fact going up substantially. Essentially, particularly for the elderly, frequently Medicaid takes up the slack, where in fact Medicare has left off. But we still have, 28 million people without health insurance in the United States. And when you look at insurance costs, what's happened is since 1999 up to 2018, premiums have gone up 239%. Whoa, right? You're shaking your head. You're absolutely right. But the employee's contribution has gone up more than that, 259%. At the same time that the employee's wages have only gone up 68%, and inflation has eaten away roughly 51% of those increases. Little wonder, frankly, that the major cause of bankruptcy here in the United States is, in fact, due to medical expenditures. And what you see here is that the out-of-pocket costs are increasing, such that the deductible for the average health insurance policy that I was describing to you before is on average roughly $1,500. In other words, before the insurance kicks in, you have to pay out $1,500. And when you look at that, what you find is that roughly 26% of people in this country really find that that's too much. And if they have fair or poor health, that number goes up close to 50%, 46%. Really find that they can't afford that out-of-pocket cost. And more than 1 million New Yorkers, and actually here in Brooklyn, 300,000 Brooklynites remain uninsured. And it just doesn't have to be that way. If you look here in terms of the costs of health care, yes, back here in terms of the European countries, the Western industrialized countries, we were in the pack. Yes, the most expensive in the pack. But what's happened is that they all have in fact increased the technology in medicine, CAT scans and MRIs and what have you, but their costs haven't gone up the way ours has, so that we are now costing twice as much as most other industrialized nations. So, how do we deal with this problem? And the New York Health Act is one major step dealing with the problem of costs in healthcare. Richard Gottfried in the Assembly has introduced this. Gustavo Rivera has been the minority chair of the Health Committee in the Senate and has endorsed this direction. And what is the New York Health Act? Well, it's a single state fund, a trust fund, in which frankly, all the Medicare, Medicaid, ACA dollars are placed. In addition, every employer's contribution to health insurance through the, premiums that they pay go into that pool. And that state fund covers every resident in New York State. Every resident. Well, that means that in fact we're covering even the undocumented. Why? Because it's both humane to do that and also a good public health. thing, you know. If you ride the subways the way I do, you want the person next to you to in fact have health insurance, right? So that in fact they aren't people communicating diseases to you. The benefits should be comprehensive, and we'll describe what we mean by that. No financial barriers to receiving care. That means you don't have those out-of-pocket deductibles. You don't have to copay. For Part B and Part D of Medicare, as you probably know, those of you who are in the Medicare age retirement range, you have to pay a premium. Part B. You have to pay a premium for Part D. Well, New York Health is going to pay those premiums. And this is funded essentially through public funds and a progressive tax form, and we'll describe that to you in a few minutes. And the amazing thing is that although we will cover everybody, I believe we can do that for less than what we are doing today. So let's see how we get to all of that. We start with what are the benefits. They're comprehensive, primary, preventive, you heard about those. Mental health, very important, and substance abuse care. Inpatient and outpatient hospital care. Prescription drugs and medical devices. Specifically, dental, vision, and hearing is mentioned as something that's going to be covered. Why? Anyone know why? Because Medicare doesn't cover those things. So this is better than what people presently get on Medicare. Long-term care, you've heard some of the needs for that. That means not just nursing homes, but in fact care in people's homes. Very, very crucial. Free choice of doctor and hospital, and kind of a unique feature, a care coordinator to assist in navigating the system. I call this a care finder, not a gatekeeper, not somebody to block you from getting care, but somebody to help you find care. The financing would be progressive. As I mentioned earlier, Medicare, Medicaid, Child Health Insurance Program, ACA funds all go into this trust fund. And then there is a progressive graduated payroll tax, 80% contributed by the employer, 20% by the employee. A graduated tax on non-payroll income, you know, the people that don't pay taxes frequently, those who get their income from dividends and investments, even landlords, right? They get rent, but you know, do they pay taxes on it? Here they will, okay? New York Health pays, as I mentioned, the Part B and D premiums of Medicare. New York Health pays county and New York State's share of Medicaid. And finally, all of this is going to cost less than we presently are spending. Ooh, my gosh, how is that? Just to show you here for the Medicare recipients, you know, we had this real attack on single-payer national health insurance by the president. We said it's going to destroy the Medicare program. Oh, what is he thinking? It's just crazy. This is so much better than Medicare as it exists now. Medicare has deductibles and copays. New York Health doesn't. You know, physician care, premium, deductible, copays, all in the Medicare program. Prescription drugs, the same problem, not in New York Health care. Dental, vision, hearing covered. Long-term care, not quite yet in New York Health, but we have the promise from Gottfried and Rivera that they're going to introduce it, okay? So this is, I think, a substantial improvement in the Medicare program. Now, where does the money come from to pay for all of this? Here you see the comparison between Medicare as it's presently structured in terms of costs that don't go to pay for care. In other words, what we call billing or administrative or managerial costs, roughly 2%, and all economists seem to agree on this number, 2 to 3%. But WellPoint, Aetna, Humana, United Healthcare, anywhere from 14 up to 18%. What does that mean? It means that of the premium dollars collected, or the tax dollars collected, in Medicare, you get 98% that pay doctors, hospitals, nurse practitioners. Whereas in private health insurance, what happens is that, you don't get that kind of money. Only 85% goes to pay doctors, or sometimes somewhere down as low as 80%. There are these big savings from single payer, billing and insurance overhead. The whole problem of, those things that you have to do, that the insurance company has to do to compete with the other insurance companies in terms of lowering premiums and costs. You can see that it's about 30 cents of every dollar compared to Canada, where it's just 2 cents. Canada being a single payer country. And here from Dr. Friedman, who is up at UMass, an economist, he shows you the more detailed ways of saving money. He argues here that there would be reduced insurance administrative costs, right? You wouldn't have to have all of those people denying claims, delaying them, so that we don't get paid for a while and have to challenge them. Reduced hospital administrative costs, because hospitals, again, have to, in fact, fight with the insurance companies to get paid. And the bulk purchasing of drugs and devices, which entity in this country gets the highest price, lowest price, on prescription drugs? Anyone have a guess? Are you? The VA, right, exactly. Why? Because it can bargain for price with the pharmaceutical industry. The problem with Medicare right now is that you have to go through a private, prescription benefit management company. So Friedman felt that there would be a total savings of $55 billion in New York State. And he admits there'll be some increase, if you eliminate copays and deductibles, that's going to cost you more, right? He also proposes increasing the physician fees, which for Medicaid in particular are lower than what private health insurance pays. Let's increase those up to what private health insurance pays. And what you find is that, it's going to be an increased cost there, including, coverage for people who presently are not insured of roughly $26 billion. But that leaves you with a savings, that he argues is close to $29 billion. So there is here, whether you believe it or not, I think, a real possibility for savings. And what you see on this slide, looking nationally, Medicare and Medicaid has kept the cost of health care down, where private insurance has gone, again, off the wall. The New York health tax essentially replaces private insurance, out-of-pocket costs, county Medicaid costs, and it gains billions in savings through administrative simplification and bulk purchasing of drugs. Here's a slide that is probably hard to see down everywhere in the room, but essentially what you see here is that people with incomes below $25,000 annually would not be asked to contribute tax money to the New York Health Act. And then you can see it goes up, so that in fact people with incomes over $400,000 are going to be taxed at close to 18% of income. And the public supports this. Okay, if you look at all voters out there and you ask them, you know, do you favor a federal Medicare for all health insurance system that covers every American? And what you find is 70% of voters support it, roughly 20% oppose it, 10% aren't sure. And when you look over here with the Democrats, they are, you know, over 80% in favor. And even the Republicans are over 50% in favor. So this is again an interesting phenomenon where there is public support for this. And as you know, this passed the Assembly in this state back on June 1st, 87 to 38, 2-1. And we had 31 senators endorse the New York Health Act, but we needed 32 votes. Technically, we should have that now. We will see how it works out. Okay? And then the question, if the legislature passes the New York Health Act, there'll be the big question, will Governor Cuomo sign it? So, what's next? Well, there's not going to be any vote on this year, that's clear. But next year, 2019, maybe we will see that. There will be statewide hearings, more attention from the media, visible support by unions and community groups, like hopefully you in this room. But what we will see is a real attack by those who oppose this. The insurance companies, the business interests, the right-wing think tanks, they're all going to try to scare people. And it's really very important that those of us who are advocates for this really understand and can deal with the arguments that are brought against it. So there has to be strengthening, more people, more money for the campaign for New York Health. So what do we get? Everyone is covered in the New York Health Act. No financial barriers to care. Lower drug and equipment prices because we can negotiate with those pharmaceutical companies. When you've got 20 million New Yorkers negotiating, that's a powerful force. No unnecessary wasteful spending and planning and control of future costs. Well, let's go out and do it. Here's some contacts. And if you really want to dig deeper, learn more about this, go to the PNHP website. There's a lot of material there that you can get. Thank you very much.
Thank you so much, Dr. Fein. So moving right along, we have Amanda Lugg. She is the Director of Advocacy at African Services Committee, and she has been working in this space as an advocate, particularly in relation to HIV and AIDS for some 20, 25 or more. Many years, and she is a wonderful voice for immigrants who can speak more to what this act and what this bill means to the immigrant space. Amanda?
All right, good evening, Brooklyn. My name is Lugg, Director of Advocacy of African Services, based in but serving African and Caribbean immigrants from all the 5 boroughs. I'm particularly honoured to have been asked to speak here this evening, as I too, like Dr. Fein, I too for the past 22 years have called the People's Republic of Brooklyn home. Don't be fooled by my accent, I just watch a lot of PBS. No, but seriously, I'm an immigrant, though my move from England to New York was one of just pure choice. What's all the noise about? Let's see what's going on across the pond. I work full-time, and I have health insurance through my employer, albeit an insanely ridiculous 4-figure deductible, but I have insurance. I wasn't running from war, I wasn't running from persecution, trauma, abject poverty, and I had no financial demands made of me by my family back home. This, however, is the diametric opposite to, dare I say, the majority of immigrants that come to our city. Certainly a very large number of immigrants, and it is most definitely the case for the over 8,000 immigrants that African Services serves each year. The physical and, as importantly, the mental health care needs of our immigrant communities are as varied in service type and number as the cultures and countries we hail from. But what we certainly do share is the reduced access. For some, it's due to worries around immigration status, or, as we've seen more recently, the general fear and confusion due to the proposed rule changes to public charge that you may have heard about. But for the overwhelming majority, we share in the inaffordability of the very health services necessary to address those mental health needs and to be able to fulfill those economic responsibilities to our families and communities back home. While New York State and City have made important strides in providing coverage and improved access to care for immigrants, such as Child Health Plus, Medicaid for pregnant women, and of course we have the safety net hospital systems, health and hospitals and FQHCs. Yet still, key populations in this state, of which immigrants are one, remain uninsured or underinsured, leading to less access to healthcare providers and higher rates of chronic diseases. And as we know, one of the main groups of immigrants that are not eligible for health insurance are undocumented immigrants. Brooklyn has always been proud of its immigrant heritage, and if I can quote from the Borough President's website, Brooklyn's diversity is a shining example of multiculturalism at work in the United States. In 2015, the Brooklyn Community Foundation estimated that close to half of Brooklyn residents are foreign-born, or approximately 1 million individuals. The report also estimated that 164,000 immigrants in Brooklyn are undocumented, accounting for roughly 7% of the borough's total population. So from Dr. Fein, we've heard this evening about what the Health Care Act is, what it involves, but what can the New York Health Act mean for our immigrant communities, for literally hundreds of thousands of Brooklyn residents? The New York Health Act would provide universal insurance coverage with no co-pays, deductibles, or premiums, regardless of immigration status. Let me say that again. Regardless of immigration status. What will the New York Health Act mean for our immigrant communities? The New York Health Act would increase the likelihood that hundreds of thousands more Brooklynites will actually go to the doctor when they are sick or in need of care. It would increase the likelihood that hundreds of thousands more Brooklynites will have regular visits with their doctor or other healthcare professionals who in turn will be able to identify risk factors and problems before they become serious. And as we know, preventative care reduces the need for expensive emergency room visits. And it would increase the likelihood that hundreds of thousands more Brooklynites' stress levels will plummet in the knowledge that they are not going to be handed a huge medical bill big enough to bankrupt them and their families. It would increase the likelihood that hundreds of thousands more Brooklynites will be happy and healthy. What can hundreds of thousands of more happy and healthy Brooklynites mean for Brooklyn? A healthy, a happy, a more productive workforce, less absenteeism, both by workers as well as by our students. In effect, a stronger and a smarter Brooklyn. New York Health Act, what's not to like? Thank you.
Amanda Lugg. Last but certainly not least, we have Maria Alvarez. She's the Executive Director of the Brooklyn-wide Interagency Council on Aging. She's been working in this space for some 22 years now, and she is the perfect person to set us up on New York Health Act as it relates to elder services. Thank you so much.
Very nice to see you. Such a great turnout at the end of the day on a holiday week. So thank you for attending this very important event. One thing, we had two very good presentations here. And one thing that I was just thinking about, at Statewide, we run helplines where people will call us to get information on how to navigate the healthcare system and their insurance and prescription drug coverage. And so we see a lot of things that are happening day to day with people who have Medicare or other programs. And one of the things that I always hear from people who are not 65 yet, they'll say, oh, I can't wait to get to 65 because then I can access Medicare. And one of the things that we know, Medicare is a great program. It's, as you were seeing here, it's the 2% of the administrative cost is what it costs, other than health insurance. However, the New York State Health Plan is better than Medicare. So you want Medicare for all, we want better than Medicare for all. The reason why we're saying that is because seniors spend an average of 37% of their Social Security checks on out-of-pocket costs. So as great as that Medicare is, they're still spending 37% of their income. We know that people 65 and over in New York State, out of those 30% only live on Social Security. They don't have pensions. They don't have, they don't have annuities or IRAs, things like that. We also know that Brooklyn has the largest amount of seniors and baby boomers in New York State. While the census will tell you that 30% of all seniors live in Brooklyn and that about 30% are in poverty, we know that our Elderly Economic Index, which basically tracks the average cost of living for seniors in Brooklyn, 76% of Brooklyn households led by seniors are not making ends meet. So so Medicare on its own is untenable for seniors, which is why New York State, being a very generous state as it is when you compare it to others, has some other programs called QMB, Quality Medicare. Those things go through the Medicaid system. So a senior can live, so somebody can live to be 65, right, and qualify to get Medicare, but the question is, can they afford to get Medicare? Because if they can't afford those co-payments, and they can't afford going to the doctor, and they can't afford their medications, and they can't afford to sign up for those programs, they're not going to get the health care that's needed. So New York Health, what they would do would be absorb all of those costs, not just for seniors, but for everybody. And then that would make sure that we have Medicare for everybody, but a better Medicare for everybody. So one of the things I'm gonna say is that it's very important to know that that while people will say, well, you have just to dispel that myth when you go out into the communities. When you hear people say, well, seniors don't care about New York Health because they have Medicare, that's not true. Seniors, number one, want everybody to have as good health insurance as they could possibly have, but they also want to be able to participate in the same way that everybody else would be able to if they had a New York Health Act bill. So the other thing that I have to talk about is long-term care. Long-term care, and I have an explanation of how New York State seniors would benefit, from this act back on the table. But long-term care in this paper doesn't talk about how it's covered under the Health Act, because right now it's not covered. It will be, it will start next year and it will be voted on next year. However, when we look at number one, in Brooklyn, 28% of seniors 65 and over have mobility issues and need extra care. If that is not covered through their health insurance, then they're not going to get care, or they're going to go broke trying to get it. So that is the other big reason why seniors, why it's very important for people 60 and over, 65 and over, to be able to participate in a New York Health Act, because in this plan, because it will become then a complete service. It won't just be your premiums, your co-pays, and your prescription drugs, which cost an arm and a leg as it is right now, but it will also be the long-term care that will help them be able to stay living in the community with dignity. Thank you.
Thank you again, Maria. Right on time. We are going to make our way into an open Q&A section. This is a point in time where you can ask your questions, and I already see a hand, but just to flag, we're going to be using something known as progressive stack, which is essentially about bringing up underrepresented voices. A lot of times, people of color, women, underrepresented minority groups do not feel do not have the opportunity to speak in these forums. So we're going to invite you all and encourage you all to step up and step back in that regard. But now, do we have mic runners, by the way? Awesome. So I'm seeing ma'am, you first, and then sir in the back, and then Judy in the middle. Ma'am in the back, in the black. So, ma'am, is that to speak?
Thank you, I appreciate very much, and very thankful to the Borough President to be holding this meeting and for all of your contributions. I'm a senior, and I do believe and agree with everything that has been said here, and that we all have a human right for affordable health care. But I also believe that we have a human right to choose the type of treatment that we want. Right now we are in a stage, a period whereby a lot of people are turning to holistic medicine, alternative medicine, and for many reasons. And we know that's going to be a big fight with pharmaceutical drug companies. But I would like to know, because I have experienced and observed suffering from not being able to choose the type of health care that I want. When I was able to afford it, great. And now that I'm not able to afford it, as a matter of fact, the Borough President talked a lot about holistic, plant-based diets, and we have holistic doctors, and as I spoke to them, the fee for going to a holistic doctor, and we're not talking about fat doctors, we're talking about doctors who are certified and qualified as doctors, and who have advanced or more knowledge on treatment of diseases which have been proven by many researchers and studies that plant-based diets and holistic medicines are healing a lot of people without the side effects and the negative things that happen with the traditional medicine. I'm not saying that regular doctors don't have their role to play, but I believe that as a human being, I was created with the right to choose, and I would like to choose who I want to heal. And I would like to know if this in your act, are we going to put on it that alternative medicine or attending or holistic doctor will be covered by such, because right now it's like, you know, one of the doctors told me, oh, Medicaid might only cover maybe 10 to 15 minutes with me, and that's it, when I might need a whole, you know, lot of hours and weeks for treatment. So I would like to find out that. There are a lot of people that are interested. It's a growing population, it's even affecting the retail companies who are manufacturers of realizing people are more educated and are going to better choices.
Yes, I think that's a very important question. At this point, in great detail, I'm not sure it is actually dealt with within the legislation. However, there is increasingly the field of integrative medicine that does recognize the importance of what you're talking about, alternative forms of medical treatment. So that's something to pay attention to keep looking for, and for us to be talking with the legislature about. I certainly feel it's very important to be able to reimburse, you know, for alternative medicines.
I just want to say one more thing. It's very easy for us to talk, read, and people to act, but in these kinds of workshops, it's provided in all communities and getting everybody involved and pressuring our representatives in government, I think we get faster action.
Correct.
Just waiting and pretending. So, you know, I believe there's a problem for a solution to every problem, and I believe in faith if we move forward with power, we can get what we want. Faster than we think.
Seeing the gentleman in the back.
To Katie, can you let me know when we return to Albany? And also, when you get word, please email all the details to me. There was some confusion when I traveled there in 2016. I should have traveled with Julie Regan, instead I traveled with a clown from my borough, traveled my borough, 3600 drove down by Woodlawn Cemetery, back on the park. And I told her, Julie, I was better on travel with you. So when you get the details, please email it to me. You have my email address?
We'll make sure that we follow up with you, sir. Just a quick note, we're gonna have time afterwards for more questions, but if we can keep things brief in your questions and also keep things like more broad, that would be amazing. So I saw next Judy, and then I'm seeing a lot of hands, so we will get to you guys.
So this is more of a, I think, a tactical question. Wouldn't this require some sort of federal waiver to get Medicare and Medicaid on board if New York should pass this?
Yes.
Yes, it does require that. And you could then ask, subsequent to that, what is the chance of getting such a waiver? And that's a very interesting question. As you know, the Trump administration has been leaning very strongly to the notion of block granting Medicaid. Okay, we certainly have not favored that, but in some ways, that's what we're talking about, is a block of Medicaid, federal Medicaid money going into the healthcare trust fund. Then the other question is Medicare. Very important. What's going to happen there? And what people have thought about is let's say they would deny a waiver for the Medicare money going into the trust fund. One of the innovative ideas that's been thought about is that Medicare has a program called Medicare Advantage, right? Which has been interpreted largely as a program that allows private health insurance companies to manage the beneficiaries' Medicare spending. Well, maybe the New York Health Act's trust fund would become the managed care program. And as that would require frankly, a waiver. You could
but
do
does
that.
It have to be voluntary for people to join an Advantage plan?
Yes, but again, what you would do, it seems to me, in any single-payer program, you would, in fact, prohibit private health insurance from duplicating the public coverage. Okay? So what you would find is that there would be no private insurance that would offer Medicare Advantage. And it would seem to me, in that context, most people would say, oh yeah, I'm going to do this.
Do you think our current president would buy this?
I don't know if he would buy it or not. I'm not sure. Our idea here is that it wouldn't be necessary for him to buy it. Because in fact, it is part of what is, the Medicare law.
And one thing I'm going to say also is that what we want is to provide one form of health care, not different choices. It should just be one plan, let's just say, or one form of health care, so that way everybody has the same access to the same care in the state. One thing that we do see is in the Medicare Advantage plans, and as soon as they start saying, the government, they love to say, well, we're giving you more choice. More choice is that these other plans are mostly private enterprises that really care about a bottom line, and that would be the difference with a New York State health plan, which would be administered by a government entity, a New York State government entity with that 2% administrative cap.
And what Medicare Advantage does is limit you to a network of doctors with whom, and hospitals, with whom the private insurance entity has negotiated, a relationship. One of the interesting facts is that Memorial Sloan Kettering Cancer Center doesn't take every Medicare Advantage program. So you get cancer, you don't have a choice of going there. But under the New York Health Act, you would have that choice.
The other thing is that the portability would not, would be sort of like original Medicare. You would be able to travel out of state if you needed to and you use your Medicare card as an ID purpose, and the state would be paying for those services. So the issue of portability, which is what most people are attracted to with original Medicare, would stay that way.
Y'all, I am seeing a man in the back, and I've got you guys. All right, well, a couple of faces I'm seeing. Let's start with the man in the back.
Thanks. Hi. I'm IBCLC. I'm a lactation consultant, and currently Medicaid is not covering lactation services unless it's provided by a doctor or a nurse, like a licensed healthcare provider. I'm an IBCLC. There is no license for lactation consultants in New York at the time. Will my services be covered because it's such preventative care and help not just the baby but also the parent who's nursing that baby? And if we catch the problem early, then they can go on and nurse as long as that parent wants to nurse their baby. And I was just reading the Academy of Breastfeeding Medicine's journal is just putting out this month an article about hypertension and how it affects the mom decades later. So this is like a long-term preventative care issue, and it's really important to get that covered also. So is that going to be included? And like the doctors who are not accepting insurance and are only private pay, or is that going to be covered? Like how does that match up?
And it's a good question. Again, it is not explicitly in the legislation now, but you know, how do you get lactation coverage presently? Frankly, there is none, right? But under the New York Health Act, you would have, it seems to me, the ability to negotiate for that, which I think right now, because you have so many multiple private health insurance entities out there, you know, you just aren't going to be able to negotiate to, in fact, get that kind of benefit. So, albeit that it's not in the legislation now, it seems to me it's possible. It's possible that negotiating for that kind of preventive benefit would be something that could happen under the New York Health Act.
Now, do I have to become like an in-network provider for this, or this is automatically covered?
Well, I think that's what gets negotiated, right? I mean, the same issue would apply to, you know, midwives, and would you have to be licensed in some way, or could you become a lay midwife? I mean, those are serious issues, no question, but they're not solved, frankly, at this point in the New York Health Act.
Hi, I've lived with type 1 diabetes for 30 years. We immigrated here from the Soviet Union because there was no access to medicine there. And the gross irony now is that insulin for type 1 diabetes, which is fatal without insulin, is one of the 7 most expensive liquids in the world. And to respected Borough President Eric Adams, it's important to distinguish between type 1 and type 2 diabetes. But so I am curious how this would allow for negotiation with pharma, because there's an oligarchy of 3 insulin manufacturers who control the mass manufacturing of it. And so Medicaid and Medicare, as we have it now, aren't able to negotiate for lower drug prices. So how would that happen?
Well, you know, I think that if you had a single entity, again, insurance entity, it would be able to negotiate with the pharmaceutical industry, provided that it represents, you know, a large number of people. Why and how do, you know, the other industrialized nations get lower prices for pharmaceuticals? Because they negotiate for those with the pharmaceutical industry. This allows for that to be something that happens, that regularly happens. So hopefully we would get into a situation where, frankly, pharma would not be able to do what they're doing with insulin. You're absolutely right. It's absurd. It's really very destructive.
Hi, my name is Robin, and I'm disabled and I'm on Medicaid. And in January, this past January, my local pharmacy stopped filling my prescriptions, stopped taking my health insurance because they said Medicaid didn't pay enough. Rite Aid does not take Medicaid. Walgreens does not take Medicaid. I have to go to CVS, which I'm lucky I can get to a CVS. But my concern is that, and this is also shared by my father, who said that his dentist, for example, would not take any health insurance because no health insurance pays him as much as he wants to be paid. So my question is, because you've been talking about lower costs, is will you be paying pharmacies and doctors enough money that they will continue to actually take our service without any copay?
That is the proposal here. And again, if you have a large enough entity, right? You know, if in fact all 20 million of us in New York State are in, you know, the New York Health Act, essentially, Rite Aid, all those places will clearly, you know, provide services. They're just not going to risk not being able to get people to use them. It's the fact that we're very fragmented, that allows for this situation where the one pharmacy can say, we're not going to take Medicaid.
Good evening. My question is, what is the difference, or how does the act itself affect single payer?
Well, the act itself is a form of single payer, right? It creates a single fund, the trust fund, that in fact is paying all the providers.
Okay, so that's the difference. And so do you think this is going to pass before they would do single payer?
Well, the issue is, will this pass before a national single payer program is, entertained or passed? And I think, yes, there is a real possibility that we would in fact lead the country in terms of having something like the real that's the way it happened in Canada, right? Is that Saskatchewan, the province, actually created a single payer program. And then, other places in Canada agreed to move in that direction. I would argue that it would really be good not so much to have a whole variety of state programs. Ultimately, we really need a national single-payer program. We always, by the way, talk about this as an improved, expanded single-payer Medicare for all. Those little adjectives before Medicare for all is what really is where we're going nationally.
Hi, my name is Kaylin Kopish, and I'm a member of National Women's Liberation. We are huge supporters of this bill, but I just wanted to ask, so we could discuss it, if the New York Health Act will be providing full access to abortion and birth control services.
My understanding is that reproductive health is a component of the New York Health Act. Yes.
And that includes full access to abortion.
Full access.
To abortion and birth control.
Well, it doesn't explicitly, as I understand it, mention abortion, but it does talk about reproductive health.
It's all right. Okay. Hi, my name is Peter Pacheco. I'm a registered nurse, and I'm NYSNA delegate, and I am sure that we're going to pass this because it is one of our key issues, and we're not going anywhere. We're committed to get health insurance to everybody in New York State, and then to the rest of the U.S. I think that we need to maybe also look at starting to divest from the health insurance companies because they are as unsustainable as the fossil fuels. And I know that there's been a big divestment movement in especially universities, and I was wondering if somebody could speak to that.
Well, I think it's a very interesting idea, and another way to, in an indirect way, to support the development of a single-payer approach. What he's talking about is the idea that, many universities actually have investments in insurance companies. And what you would want to see them do is actually to withdraw their investments in U.S. healthcare, so on, as a way of saying, well, look, we really want to move toward a single-payer approach to this. whether we can, get those entities to do this is a very interesting question. It certainly is an exciting idea that students might begin to make those demands on their universities, that faculties might. The same would be true for other nonprofit entities, where one might in fact see this as a demand. So it's an interesting idea. I'm not sure that anyone has actually pursued it.
Yeah, but it's also very interesting because many of the institutions and health insurance companies are merging these days. While Cornell, Mount Sinai has its own HMO. So yeah, it's interesting how what's happening actually is that they're all merging, and that's not very good because, again, it's a profit-making institution or proposition. They claim to be nonprofit, but when you look at what their objective is, it's really not to provide the best service. They're looking to be efficient by cutting costs. From an experience of a person who works with seniors, senior citizens consume about 60% of healthcare in this country. But when we look at the measures that they take to provide healthcare, when they talk about telemedicine, when they talk about more ambulatory care services because they want you to go home and not stay in the hospital, and they want they want to discharge you without the proper plans and not the proper home care available. That is a contradiction. So it's very much a contradiction of asking people to divest themselves from a system that they're trying to monopolize. So I think that's another conversation for another time.
No, I think it's an interesting proposition. I mean, one thing that is, again, very interesting about New York is that none of our hospitals are explicitly for-profit institutions. What does that mean? It means that they don't actually have investors and get dividends, essentially. Yes, they can make money, but that money then usually has to be, in fact, plowed back into the provision of services, or it may go to some of the CEOs and high management folks in the nonprofit entity. But you don't have a situation where you actually are paying dividends to investors in, hospitals in New York State.
So in the interest of time, before the Q&A, but please stick around afterwards and have more of this conversation. So I'm going to end with Ann over here as well as this gentleman right here.
Hi, so another Senate, we were talking about having national system versus statewide system, and I know that Governor Cuomo has multiple times said, I don't think it's going to work on a state level, it has to be done on a national level. And also his concern about the large costs sort of upfront in the first years before sort of reducing costs. I mean, I'm a huge advocate, I'm here with a lot of these ladies here advocating for it, but what can we do to respond to that?
Well, one of the interesting things that has happened is that there has been an economic analysis done of the New York Health Act by the Rand Corporation. It was before a criticism of Gerald Friedman that he was a little bit of an advocate for single payer, but the Rand Corporation clearly isn't. And the Rand Corporation came out favoring and saying that actually it was feasible financially for New York to create through the New York Health Act, a single-payer state situation. So what we have actually is a, middle of the road, I'm not sure I'd call it conservative, but a middle of the road foundation that's done an economic analysis that says it's possible. It's possible to do this and to save some money in the process. Yes, initially there may be some, the budgetary cost of this will look very high because in fact healthcare is a very expensive proposition. But it will be cheaper ultimately for both employers, employees, Medicare people who are contributing to buying premiums, Part B and Part D. All of those people are likely to do better off in terms of their financial investment in this. And the Rand Corporation has said, yeah, it's possible. And that's, I think, what we would bring to Governor Cuomo and say, look, there is an entity that is not, a left-wing foundation or anything of the sort that has in fact made that analysis.
And another thing is that when we've gotten to a point where healthcare health insurance companies are dictating what healthcare is being provided, we know that there's trouble, that is trouble. So, putting it as a single payer, entity where there's only one organization that is overseeing the payments, there's no ad, not 18%, 30 times. New York State has about 30 health insurance companies, so those figures that you were talking about, 18%, of each company has to goes to things that are not healthcare. And by the way, from a Medicare perspective, those are taxpayer dollars that are going to pay for private corporations and private salaries and other things that are still not providing healthcare. So there are different interests that are being created that is not for the benefit of us or our well-being. So I think that that this is a much better solution. It's more pure and it's a lot more efficient when you're only spending roughly 2% of the budget on something on administering a program.
So I think for our last question, jump over here, and then we're going to close our Q&A section.
I'm Benjamin. I'm a medical student at Downstate. This is a question for Dr. Fein. So I'm curious what the conversation is like between doctors regarding single payer, and especially nationally, because medicine as a whole tends to be conservative, at least out of New York State. So if you speak to any compelling arguments you've heard against single payer physicians, because that would be unexpected blowback in the national conversation about single payer.
I think what's interesting here is that it depends a lot on the specialty of the physician that you talk with. Now, polls have been done, using the AMA master file, so that it's representative of a broad section of physicians in the country, and 58% of the respondents actually say they favor, government involvement in the system, and even single payer. So that conversation is there. But I think, yes, there are particular specialties that are probably not going to be able to continue to be the very high earners, such as, cardiac surgeons, neurosurgeons. They tend to have, multi-million-dollar incomes. Primary care doctors, they will clearly do better under a national health insurance system. And, if we look at the professional societies in this state, the one professional society that has actually endorsed the New York Health Act is the Family Physician Group, okay? This is a dialogue that is going on, certainly among physicians. I have to say, really a fascinating thing. Today, I just had lunch. Serendipitously, I just sat down next to one of our very senior physicians at Cornell, and he said, you know, things are just so bad in my practice. I just want to see this, in fact, go to what you're in favor of. He kind of knew I have a reputation at Cornell. Have it go to a single payer approach. So, you know, I think this is very actively being discussed. You know, it would be interesting for students, I've encouraged them to do this, to actually try to do a survey of their faculty and get an idea. When this was done at the University of Chicago, they again were able to get roughly a majority of respondents who favored moving in this direction.
I think that's a really great place to end. I want to thank our panelists so much for their time and for their expertise. It's awesome to work with you all. I know we cut things a little short, so please stick around and continue the conversation after, but I'm going to turn it over to Katie.
Okay, just a few closing words. Everybody has the pledge to action form. We don't want you to leave tonight without the opportunity to stay connected with the Campaign for New York Health and the Caring Majority. There's a few key flashpoints for activism in the near future. First of all, I don't know if it was mentioned, I think it was, that the New York City Council has introduced a resolution in support of the New York Health Act. Cities and counties all over the state, I think almost 20 have actually passed such resolutions, and we haven't seen it happen in New York City yet, which we think is unacceptable. We're hoping to change that in the very near future. There is a hearing where you, anyone, the public is welcome to testify on Thursday, December 6th at 1 p.m. in City Council to talk about why you want the New York Health Act to pass and why New York City needs to get behind it. So that's on here. Check that box if you'd like to attend or speak at that event. The Caring Majority is going to be hosting a teach-in strategy phone call to learn more about the fight to win single payer and universal long-term care on December 12th. You'll see the RSVP information on the form. And they're having a strategy meeting on December 13th. These are some key events in the near future you can plug into. And a number of other ideas about how you can spread the word in your community. We have a campaign where we're asking businesses to endorse. We're canvassing and having conversations with our neighbors using a survey, the Healthcare Rights to Access survey. We are going to push for a vote in 2019 in the Assembly and in the Senate. I know Dr. Fein said there would be no vote, but I'm here to say that's up to us if there's going to be a vote on the New York Health Act in 2019. A spirit for a grassroots movement making this happen in New York. Oh, in 2018. Well, there was a vote in the Assembly, right? We passed it in the Assembly, but not in the Senate. I see, I understand. So it's really important to know we're going to keep pushing and we're going to keep the heat on the governor to do the right thing, and together we can make healthcare happen in New York. Thank you all so much.
So one of the things that I want to say is that everybody here is going to go and talk to people about this. There are a lot of common things that people say, trying to make this things that repeat. One of them is just going to be all the people working in the insurance industry and all the other support industries. Actually, like, there should be like a very small component of these speeches that maybe a single slide that dedicates. The bill does account for retraining. The bill does include provisions for retraining. I think that is missing with this presentation. And most of the audience is concerned with that. I'm not concerned with that because, you know, as local motivation engineers,